Hello everyone. My name is Ola. For those that don't know me, well, you should know me. And today in the Social EM lecture series, we're going to be talking about racial disparities and acute pain management. I would like to give a shout out to the Social EM team. So, yeah, going over the outline, this is our outline for the lecture. You see the learning objectives, correct? Cool. All right. So some of the things that I'd like the audience to be able to do at the end of this is understand some of that historical context surrounding medical racism, be familiar with the term systemic and structural racism, understanding the meaning of implicit bias, identify discrepancies of pain management within the emergency department, and most importantly, recognizing actions we can take to be anti-racist. Black people's nerve endings are less sensitive than white people's. Black people's skin is thicker than white people's. Black people's blood coagulates more quickly than white people's. Does anyone in the audience have any idea of what time period these statements were thought to be true?
No.
Yes. Well, as surprising as it may be, these statements full of 19th century ideology have been demonstrated in modern medical institutions. In a very well-known 2016 landmark study done at the University of Virginia, 222 medical students and residents were recruited and tasked with providing pain ratings and treatment recommendations for both a Black and a white target. In addition to pain ratings, beliefs about biological differences between Blacks and whites using 15 items were measured. 11 of these items were false, like the ones shown above. Medical students and residents would grade the perceived accuracy of these statements using a scale ranging from definitely true to definitely not true. The study that's shown found that similar to white laypersons who were used as the control in study one, many white medical students and residents held beliefs about biological differences between Blacks and whites, many which are false and fantastical in nature, like the ones that are bolded. Furthermore, study two also reveals that white medical students and residents who endorsed these false beliefs showed racial bias in the accuracy of their pain treatment recommendations. Basically, those who held more of these beliefs reported that a Black patient would feel less pain, and these providers were less accurate in their treatment recommendations for the Black patients compared to the white counterparts. And about half of these trainees surveyed, they held either one or more similar false beliefs. What's most shocking is that 40% of first and second year med students believed that Black people had thicker skin than white people. This was done in 2016, less than a decade ago. So here I am going to show four well-cited studies to really drive home the point that racism and bias play a role in the physician-patient interaction. In the first study I have listed, published by the National Medical Association in 2007, conducted in PCP offices, they found that relative to other racial groups, physicians are twice as likely to underestimate Black patients' pain. In this study, published by the Social Science and Medicine Journal in the 2000s, so that physicians implicitly prefer white patients, falsely viewing them as more intelligent and more likely to follow professional advice. This third study, a retrospective study comprising over 800 pediatric patients published in 2013, found that patients that were identified as African American, biracial, or Hispanic had significantly lower rates of opioid analgesic prescription when compared to other ethnic groups. And lastly, more recently, this study published in 2021 using standardized patients showed that physicians with greater implicit bias provided lower quality of care. This was done using standardized patients. Lower quality of care, including fewer renewals for an indicated opioid prescription and less patient-centered pain communication. So where does this all come from? Unfortunately, with most disparities pertaining to Black people within the United States, a large part of it stems from slavery. Is anyone familiar with any of these images that I have shown on screen? No worries. It'd be kind of weird if you were able just to quickly identify some weird old racist photos. But anyway, beliefs that blacks and whites are fundamentally and biologically different have been prevalent in various forms for centuries. At least in the United States, these beliefs were championed by scientists, physicians, and slave owners alike to justify slavery and the inhumane treatment of black men and women in medical research in the 19th century. In the top left, you have Samuel Cartwright, who coined the term drapetomania, which he described as a time was a disorder for slaves wanting to run away, with a cure by whipping the devil out of them. He also wrote that blacks bore a Negro disease, making them insensible to pain when subjected to punishment. What's even more interesting, one of the founding fathers, Thomas Jefferson, published an article stating that black people had a lack of lung capacity. And many physicians during that time, including Mr. Cartwright himself, saw forced labor and cotton picking as a way to vitalize the blood and correct the problem. Cartwright even built a spirometer to justify his racist views. In the middle picture, I'm sure many are familiar with the father of modern gynecology, Marion Sims, who used the notion that black people feel less pain to mutilate the genitalia of enslaved women. And even more recently, well into the 20th century, the top right picture shows researchers continuing to experiment on black people based on the assumption that the black body was more resilient to pain and injury. The military covertly tested mustard gas and other chemicals on black soldiers during World War II, and the U.S. Public Health Service, in conjunction with the Tuskegee Institute, studied the progression of untreated syphilis in black men from 1930 to 1970. Racism is so institutionalized in the American healthcare system. Even Cartwright's footprint remains embedded in current medical practice today. Most available barometers have a race correction, which controls for the assumption that blacks have less lung capacity. Again, a statement that was made during slavery to justify blacks needing to pick more cotton is still being shown in some spirometers today. Thankfully, there's a movement away from this current outdated thinking. However, very accessible sites like MD Calc still use this race correction. As of 2021, the estimated glomerular filtration rate is no longer thought to be elevated in Black people. I mean, I hope one can understand how overestimating the kidney function in one population could lead to adverse outcomes. So before we go on, I want to go over some definitions that are very central to this talk and understanding of racism in general, and especially in the medical field. First, we'll talk about race. Race refers to the social construct and categorization of people based on perceived shared physical traits. Emphasis on a social construct. Keep in mind that in the 20th century, biologic, anthropologic, population genetic analyses of human variation demonstrated conclusively that anatomically modern humans do not have biologic races. However, socially defined races continue to be viewed as if they are accurate reflections of biologic variation within our species. The next definition I talk about is racism, which is defined as prejudice, discrimination, or antagonism by an individual, a community, or institution against a marginalized person or people due to their ethnic or racial backgrounds. The most important definitions I want to try and highlight today are structural and systemic racism. Structural racism are the processes of racism that are embedded in the laws, policies, and practices of society and its institutions that provide advantages to racial groups deemed as superior, while differentially oppressing or otherwise neglecting racial groups viewed as inferior. Compared to systemic racism, it emphasizes the role of structures, the laws, policies, institutional practices, and entrenched norms that are systems scaffolding. Whereas compared to systemic racism, it is emphasizes the involvement of whole systems and often all systems, political, legal, economic, including the structures that uphold these systems. Structural racism fits in the definition of systemic racism. The picture shown, the bottom of the iceberg, I want you to relate those practices more to systemic racism, which consists of the societal systems and structures that expose people of color to health harming conditions and that oppose opportunities to promote good health and well being. Next, let's talk about bias. Biases. These are things that all humans have. I would most likely want to talk about implicit or unconscious bias, which is a negative evaluation of a person on the basis of that person's race, gender, sexual orientation, or other factors and occurs outside of conscious awareness. Biases are influenced by personal experiences or beliefs. That's why I like this image so much. It's showing the implicit bias within our own cognition and showing how these outside factors kind of have some type of effect on that. As physicians, we have unconscious biases like everyone else. And unconscious biases against Black people and other impoverished communities have been associated with changes in the way physicians communicate with patients. I would like to not believe that all racial and ethnic disparities in pain treatment are intentional. Instead, I think these are very complex, multi-product uh, influences, including implicit bias that providers don't even know they have, in conjunction with the effects of systemic and structural racism. But that is why it is so important that we as physicians need to continue to challenge our own inherent thinking. So now that we got some of the history and historical context out of the way and definitions, let's look at some data from our own population, from our own clinical area. This first study that I'm showing is a retrospective study of over 7,000 patients published in 2022 by the UC Davis School of Medicine, with a study population of about 45% non-Hispanic white, 19% Latinx, and 8% non-Hispanic Black, which concluded that Hispanic, Black, and Asian patients were significantly less likely to receive opioid analgesia than white patients when presenting to the emergency department with abdominal pain. In this study, Black patients were also less likely than white patients to receive non-opioid analgesia. My second study, which I'm referencing, published in 2022, a retrospective cohort study of 500 randomly selected patients presenting to a large academic emergency department in upstate New York with a chief complaint of headache. This study's population consisted of about 55% white and 45% Black, Indigenous, people of color. This study found that white patients were more likely to be assigned an ESI score of 2 or 3, and their Black, Indigenous, people of color counterparts were more likely to be assigned an ESI of 3 or 4. There are also clear differences in prescribing patterns. Black, Indigenous, people of color patients were significantly more likely to be treated with Tylenol and Motrin, and their white counterparts were also significantly more likely to receive a head CT or a neurology consult. My next study, which was a very large study, 2021, comprising of about 260,000 patients, abstracting data over a decade from 2003 to 2015 using the Premier Hospital Database, which includes about 20% of discharge data within the US, including a population of about 84% white, 6% Black, 10% Hispanic. It essentially concluded that Black and Hispanic patients in American emergency departments with acute renal colic receive less opioid medication than white patients. Black patients were also less likely to receive Toradol. This is a study of over 260,000 patients. What about the kids? So this 2015 cross-sectional study published by JAMA included about 1 million patients less than 21 years old with a diagnosis of appendicitis. Population of about 86% white, 9% Black, 3% Asian, 1.5 other, and 22% Hispanic. This large study published in JAMA concluded that Black children are less likely to receive any pain medication for moderate pain and less likely to receive opioid medication for severe pain, suggesting a different threshold for treatment. Still not enough to convince you? This is a meta-analysis and systemic review published to the American Journal of Emergency Medicine in 2019, which included 14 studies that met inclusion criteria, with a total study population of over 7,000 non-Hispanic white, 1,500 Hispanic, and 3,000 Black patients. The paper concluded that Black patients were less likely than white patients to receive analgesia for acute pain, and that Hispanics were also less likely to receive analgesia. At the very least, these studies demonstrate that the presence of racial disparities in the acute management of pain within the emergency departments in the United States. So why? Why does this happen? Well, it's not clear. It's likely a very complex and multifaceted and may include factors such as implicit bias, language barriers, cultural differences in the perception and expression of pain, and the institutional differences in emergency departments that serve mostly Black and Hispanic patients. And then most importantly, with everything I'm talking about in this lecture, also affects of structural and systemic racism. So how does that affect our patients? For my Naruto fans, and now this world shall know pain. Well, let's talk about some of the consequences of unmanaged pain. Some of these can lead to increased patient morbidity, poor longer-term outcomes to delayed recovery, development of chronic pain syndromes, sleep disturbances, physical function decline, declines in social and recreational activities, depression, anxiety, cognitive impairment. Overall, uncontrolled pain worsens healthcare outcomes and leads to increased healthcare and utilization costs. So now the most important question, what can we do? So I know this is a lot. It's heavy. It's depressing. This is a generational issue. It's overwhelming. But what can one person do? But we're physicians. We have to do something because racism is a public health crisis. At this time, I would like to call on the audience. There are no wrong answers. I would like to ask you guys your thoughts. What are some things that we can do to tackle this healthcare disparity?
Being advocates not only for our patients but for our colleagues as well too, like calling out things that are clearly like wrong and having those difficult topics and conversations amongst each other is one thing.
Yeah, definitely. Holding each other accountable, holding our healthcare systems accountable, making sure that they're safe spaces. I think these are all very important things. As physicians, we took a Hippocratic oath, which in it we are called to uphold specific ethical standards in our practice. Racism and implicit bias affects the quality of life of our patients, especially in the population that we are privileged to care for here at Kings County and across the street at SUNY Downstate. It is not enough to be not racist. We must adopt a policy and mindset of being anti-racist. So what does that look like? Things we can do within our own communities and institutions. Collect data. If bias exists, it should show up in the data. Every healthcare setting needs to collect data on pain management by patients' race, ethnicity, as well as gender, insurance status, and other significant characteristics. Healthcare systems need to review the data regularly and create strategies to address disparities. Bias. Identifying our own biases. To address our bias, we first need to recognize that it's there. Some institutions recommend taking the Harvard Implicit Association test. This can also be a very valuable experience of self-awareness and humility for us as physicians. We must understand that implicit bias is common, even among people who are more progressive in nature, and that we all internalize messages from our culture, and that implicit biases are not the same as discrimination or racism. Another way to identify our own bias is to pay very close attention in everyday life and in patient interactions when we notice that we may have made an assumption. For example, the next time you have a patient that's drug seeking or in a vaso-occlusive crisis, please ask yourself, how does this patient's race factor into my assessment of this patient? Educational programs. Learning about disparities in pain management can help clinicians and trainees improve their practices, and understanding that even the best of us can still harbor implicit bias. Education must include effective strategies for reducing the impact of bias on patient care, such as using clinical guidelines and standardized checklists. Finally, institutions should evaluate the impact of implicit bias education on patient outcomes on a regular basis. Remove as much individual discretion as possible. Using clinical guidelines, standardized checklists, and system-wide protocols leaves less room for individual discretion or bias. I like to talk about this 2018 randomized control study comparing standard weight-based dosing versus patient-specific opioid dosing for the management of acute vaso-occlusive crisis. This study essentially found that patient-specific dosing had greater improvements in the pain experience, admission rates, and lack of negative side effects and safety events compared to the standard weight-based strategy dosing of pain. So maybe next time you have a sickle cell patient, ask them what works best for them instead of using a provider-driven strategy that might be home to biases. And most importantly, we need to adapt an anti-racist mindset. It is not enough to be not racist. We must be anti-racist, especially in this climate of discreditation of programs meant to enhance diversity, equity, inclusion. This means understanding the structural and the systemic injustices within America's history and the American healthcare system that have led to the inequalities covered in this lecture and beyond. What does this actually look like? This looks like advocating for increased funding for healthcare systems in impoverished areas, recurrent education on implicit bias, examining institutional policies with an equity lens, additional med school and resident education on racial disparities in healthcare, finding ways to provide awareness of racial issues and self-examination for clinicians, improving diversity in clinical areas, especially regarding racial depictions of cutaneous manifestations and interactions with the diverse, standardized patients, detecting and combating racism in real time through use of patient and staff submissions and dashboards, training more Black and underrepresented physicians, ensuring accountability through structured evaluation of programs meant to address segregated care and other manifestations of racism. And lastly, challenging hospital and university leadership to initiate transformative change that moves beyond performative anti-racist statements, because racism is a public health crisis. Lastly, I would like to circle back to that 2016 landmark study published by the University of Virginia. So at this historical Black college, Howard University, they replicated that same study within its own trainees. Using about half the study size, they found that compared to that landmark 2016 trial, their own residents and medical students held less biases and held less of these false beliefs about biological differences between Blacks and whites. And if they had any false beliefs, it did not impact the treatment of the sample patients, and their assessment of the pain was not impacted by the patient's race. What's most notable is the white respondents in this study also did not exhibit any racial bias in the pain assessment or treatment recommendations, indicating that perhaps active teaching and implicit bias training by these HBCUs counteracts racial bias in these individuals. These findings strongly support the need for pipeline programs to improve exposure, recruitment, development, and retention of Black students in medicine, as well as the continued support of HBCU medical schools. So in summary, the historical roots of the US healthcare disparity stem a lot from slavery. Medical racism is still very prevalent today. Understanding structural and systemic racism is key to making any change or leeway into these racial disparities. We need to continue to challenge our own implicit bias and always think about how our own implicit biases may be affecting the patient interaction. If there's anything you take away from this, is to show you that we are undertreating our Black patients' pain. Please, when you are evaluating these underrepresented, these lower socioeconomic patients, please always just keep in mind how possibly the patient's race may be factoring into your own assessment. And I'm going to continue to say this. It is not enough to be not racist. We must be anti-racist. These are my references.